Welcome to the Radiology Vault, an open repository for radiology educational content designed for learners and medical professionals. Presented by the Michigan Medicine Department of Radiology.
Hello, my name is Krishna Perni. I'm with Michigan Radiology, and today I'm going to be talking about three common upper cranial nerve symptoms, including anosmia, vision loss, and diplopia. I have no disclosures. So this is a case-based review of cranial nerves associated with vision and smell. Again, symptoms include anosmia, vision loss, and diplopia. Pathologies include tumor, inflammation, vascular, and then trauma, congenital, and other causes for cranial nerve palsy. The first question is, which of the following is not associated with anosmia? Let's read through those, and then the answer is that all of the above can cause anosmia, and here are the two olfactory bulbs. So various skull-based lesions anteriorly can involve the olfactory nerve in the olfactory groove or cribriform plate, resulting in anosmia, especially when you have bilateral involvement. On the bottom left, you have a case of squamous cell carcinoma invading the orbit and skull base and intracranially. And then here you have anesthesia neuroblastoma. You see cysts associated with the tumor interface with the brain. Here you have a pouching of CSF into the nasal cavity, and this is a nasal frontal encephalocele. And then here you have a meningioma along the planum sphenoidale, which is also a cause of anosmia. So next question, which of the following ischemic processes most directly correlates with disruption of the visual pathway at the lateral genital body level? Here are your options. And the answer is internal cerebral vein thrombosis. So a quick review of the pathway. Here you have the optic nerve showing restricted diffusion. So this is an ischemic optic neuropathy. There's ADC abnormality. Here's an hyperdense internal cerebral vein with hypodense thalami, and then bilateral hemorrhagic infarcts in the thalami. So this is an internal cerebral vein thrombosis causing lateral genital body infarction. Lastly, it can involve the optic radiations and cortices directly. So here's an example of a posterior cerebral artery infarct causing those symptoms. Next question, which of the following is not a disease process that affects cranial nerve 3? Benedict syndrome, uncal herniation, lateral midbrain infarct, or PCOM artery aneurysm. And here's the cranial nerve 3. Answer is a lateral midbrain infarct. The reason is that a medial midbrain infarct would affect the oculomotor pathway. Here in this case, it affects the nerve 3 nucleus directly. A lateral infarct spares this area. Other possibilities are cisternal portion be compressed by a large posterior communicating artery aneurysm. And then you can have edema or mass effect causing uncal herniation and compressing the cranial nerve 3, which is seen normally on the right and then not seen on the left. So that's another cause of nerve 3 palsy. Okay. Lastly, which of the following is not a disease process that directly affects cranial nerve 6? Here's a list of options. And here's a picture of cavernous sinus with the various cranial nerves inside of it. The answer is all of the above can affect cranial nerve 6. And I'm going to show you some cases. So this bottom case is an MS lesion involving the abducens nucleus. And then as you go further out, you get into the prepontine cistern, and then a meningioma here and here and here in the retroclavicle region can actually affect cranial nerve 6. You could have a trauma, a fracture through the skull base that nicks cranial nerve 6 and also causes a palsy. And then lastly, in this example, nerve 6 can be injured in the corticocavernous fistula. Higher pressures, because it's free-floating cavernous sinus, higher pressures can cause compression. And here you see like early filling of the superior and inferior ophthalmic veins. You see dilated cavernous sinus bilaterally on both of these images. So in conclusion, anosmia, diplopia, and vision loss are symptoms associated with multiple upper cranial nerves, especially nerves 1, 2, 3, and 6. Cranial nerve forward pathology is rarer, but may also cause diplopia. And cranial nerve pathology may involve the brainstem, cisternal spaces, or distally in the head and neck. Thank you for your time.